Good afternoon, everyone, and welcome to what is described as an instructional session. There has been a room change, so if you're here to find out about nasal surgery in airway, you better leave, because you ain't going to get what you expect. The entire audience leaves. Gielgud. And if you see anyone at the Gielgud who's expecting to find out about sinus surgery, send them up here. So what I think we might do is we may actually pause for a moment or two, because there's still people coming in who I think are coming from the Gielgud, who haven't looked at their app, myself included. No, it's a last-minute change. So I think we'll just start. So this is all about snoring and the nose. No, it's not. Sorry, it's the wrong one. External approaches to the frontal sinus. I was asked to do an instructional session, and the reason I was asked to do an instructional session is I am old enough to have been trained in the external approaches to the sinuses in the pre-endoscopic era. However, I am an endoscopic sinus surgeon, amongst other things, and I only resort to this on occasion. So what I would like to do this afternoon, as I'm keeping you all from the pub in this last of the day slot, is look at open approaches to the frontal sinus. And I'd like to introduce a concept that I call incremental surgery. And so what I would hope is that for those of you who are at early stages in your training, there may be some instructional pearls that you will pick up. And those of you who are more senior and more advanced in your sinus surgery may also pick up some tips. So we'll discuss the indications of this incremental group of techniques. Look really at some tips. This is, again, as I keep saying, it's instructional. We're not going to think about this in a high academic way. We'll illustrate it with some cases, and these are cases from my own practice, not theoretical things, and I'll present them truthfully, warts and all, and then hopefully there'll be time, if any of you are still awake, for some questions and discussion. I've got to break this news to you. It may come as a shock, despite what you've heard, but endoscopic techniques are not 100% successful, okay? And that's why we often need something to fall back on. We're often told that we can do everything with the telescope and we just need to drill bigger and bigger holes, but that's not the case in my experience. So what I'd like to do is take you through a staircase of increasing difficulty in open approaches to the frontal sinus. You'll notice that this sort of badly drawn staircase is uneven, and I did that deliberately because some of the steps on this staircase are bigger steps than others. The first step at the bottom is the old-fashioned, tried and tested frontal trephine, which should be something that should be in the repertoire of most junior rhinologists. And by the time we get to things like the osteoplastic flap and the frontal sinus obliteration operation, things are getting a wee bit more advanced. So let's look at the first step and see where we go from here. So the first and most important thing is to understand the embryology of the frontal sinus. And being a simple surgeon, I thought about a way of explaining this to you that didn't involve complex embryological diagrams. So this is literally my back of an envelope drawing. And the important thing to remember here is that the frontal sinus, although it is a highly variable sinus, always starts from the frontonasal bud embryologically, and it pneumatizes between the leaves of the frontal bone to varying extent, but it always starts here in the frontonasal bud. Some people don't have much in the way of a frontal sinus, and some people seem to have the entire frontal bone pneumatized. But you must remember it starts in this position here, roughly below the nasal process of the frontal bone. And that's important when you come to do a frontal trephine, because if you're a young ENT surgeon, perhaps doing an emergency case, taking a drill to someone's forehead is quite a scary thing to do sometimes. So I try to teach a technique which I'll show you in a moment. So first of all, why would you do a frontal trephine operation? So as I've suggested, there may be a skill deficit. And what I mean by that is that you may be a low hours sinus surgeon, you've maybe done some simple FES, some uncinectomies, antrostomies and so on, and here you're faced with having to do an emergency perhaps and open up the frontal sinus. And frontal recess surgery is not for the faint-hearted. You may find yourself in a department in the middle of the night or whatever, trying to deal with a case where they don't have sufficient kit, proper instrumentation for you to do a frontal recess approach endoscopically, and so you may wish to go for the safer, simpler, get out of jail, go home quickly frontal trephine. This patient here presented with a pyocele and it actually eroded through the bone, and in a situation like this, it's sitting asking for it. It makes no sense to start operating in the frontal recess in a bloody field in an infection when you have the answer sitting right in front of you. Often you may be called upon by your neurosurgical colleagues to drain the frontal sinus in a patient who has a brain abscess, which has come from sinusitis, and again, a quick solution which will tide the patient over until they eventually need surgery is to do the frontal trephine. And then another indication is the adjunct to the endoscopic procedure. Even in this day and age of image-guided frontal sinus surgery, it is sometimes nice to be able to do the trephine and trickle some fluid in through the frontal sinus and identify that you have fully opened the frontal recess from below. So it's a useful trick in difficult and complex frontal sinus. And again, patient factors. This was a very septic, ill diabetic patient with a pyocele who was not really fit for anything that was going to take longer than about 25 minutes or so. So these are the sort of reasons that you may find yourself doing a frontal trephine. So this is where I introduce what I've called my rule of thumb, and I've taught this for years, and when I teach on various sinus courses throughout the world, a lot of the younger delegates seem quite keen on this, and so I thought I'd stress this a wee bit and demonstrate it to you. It's a nice way, perhaps a bit simple, but it works every time. And it works every time because of this business of the way the frontal sinus pneumatizes from this position onwards. You've got to imagine that you superimpose a clock face over the orbit, and we have this magic rectangle with these positions of 10 past 10 or 10 to 2 on the clock face. You're wondering what he's talking about. Well, I'll try and explain it to you. If you imagine that clock face, and on the patient's right eye, you place your thumb horizontally over it, at the 2 o'clock position, that is pointing directly at the surface marking of the entry for drilling in to the frontal sinus. It works every time. We'll show you. On the other side, it's a 10 o'clock position. It's pointing right at that nasofrontal bud region. Now, this patient may well have a frontal sinus that goes all the way up to their vertex, but you'll always hit the frontal sinus there if indeed they do have a frontal sinus. So, draw this wee mark on your thumb, put it over the eye, and you can also use your thumb to draw around to make the incision. So here we see the thumb in the position, and Mr. Sharma, who's in the audience today, takes his felt pen and he marks opposite, in this case, the 2 o'clock position. He then uses his thumb to draw around, And that means that you don't get an epicanthic fold. Your incision is far enough out. Straight down to bone, and if you watch closely here, you can see the 2 o'clock position being marked and pointing straight at the area where you want to drill. You can take your drill and, with some irrigation, drill down, and I tell people to, what we used to call blue lining in otology, don't go all the way through, and then use a blunt probe to pop through the mucosa into the frontal sinus. And once you're in this case you see some pus coming out if you look very closely, but you now have your nice frontal sinusotomy through which you can irrigate and look from below with your telescope. So I commend that technique to you, especially if you're a lower surgeon. Draw on your finger and use that to identify where to do the trephine. So another question about the frontal trephine. In the old days, we used to talk about whether you put in an external drain or not. I think I've sort of moved away from this now. I would do most of my emergency stuff endoscopically, but in the occasion where you have an abscess or a pyocele, it's the middle of the night, you can put in an external drain until the next morning and the patient will settle down and eventually come back for their definitive sinus surgery after they've had a full course of steroid and antibiotic, and the field is much improved for your senior rhinology colleague. So that is the frontal trephine. That was our first step, and we talked about using your thumb as a poor man's surgical navigation system. Where do we go after trephine? Well, the next step up was a fenestration operation, and this really is not much of a step at all. What you're going to do here is you're going to do your trephine, and then you're going to open up the frontal bone further to gain access to the frontal sinus from the external approach. You might do that if you're dealing with a tumour. We've just had a very interesting session on inverting papilloma, and sometimes you need to access inverting papilloma. You might want to do it if it's a difficultly placed osteoma. You can get some of them endoscopically, but some of them are just awkwardly placed, and by doing a fenestration, you can get access that way. If you need lateral access, or if the bone is extremely sclerotic, we've had patients where we've been drilling from below with the endoscope and we're getting absolutely nowhere. We just seem to be drilling forever, and then you can just pop upstairs and open up the trephine and make it bigger. Having done that, the question is, you may end up with a hole like this. This was a patient with an awkwardly placed anterior table osteoma, which was defeating the angles of the scope. Having left a defect that size, you can actually close that up with just sewing the muscle and skin closed, and the patient doesn't have much of a problem. But one of the things we use if we have a larger defect is to put a PDS sheet, polydioxone sheet, the same stuff that you have on your suture material, comes in small sheets that look like the windscreens from Meccano cars, if you ever made a Meccano car as a child. And these are absorbable, and you can lay them over the area and close the wound on top of it. So that's the fenestration, a very small step above the initial trephine. Now we're starting to get into bigger steps. The riser in this step is quite significant. Even though endoscopic surgery seems to have overtaken everything we do in the frontal sinus, we have a steady flow of referrals for patients who ultimately need to be managed using the frontal osteoplastic flap. It's an old operation. It's been around for a long time. Interestingly, the initial descriptions of it are, in my opinion, erroneous. And if you try to follow the original textbook descriptions, I'd be very pleased if you would come and show me how you can actually do it. So over the years, we've developed our own way of doing this procedure, and I'd like to share some of that with you today. This is a sort of a top tips on how to do a frontal osteoplastic flap. And we have a small video of that and the obliteration procedure to show you too. So this is a paper which some of my trainees and myself wrote some time ago now, and it was really a revisit of the osteoplastic flap. There's a famous cookbook, Mrs. Beaton's cookbook, and this is a Mrs. Beaton's approach to how to do this operation. So again, if you're about to embark on one of these, have a look at this. It's got some of the tips that we've gleaned from years of doing it. Why would you do a frontal osteoplastic flap? Well, for very far lateral lesions, we used to talk about a vertical perpendicular plane through the center of the orbit, and anything lateral to that gets quite sporting to access with a telescope. I know that we can go further and further lateral these days, but it may be that it's easier to do this for lateral lesions. I do this in patients who have been sent to me for revision. They're perhaps revision inverting papilloma, and they have anterior and posterior tables of the skull eroded, and you can see that there's lateral involvement. And I get quite nervous peeling things off dura at the limits of my endoscopic reach. Not because I can't quite reach the tumour, but I know that if I make a hole in the dura, then I'm going to have trouble fixing it from that far below. So in patients like this, I'll often resort to the osteoplastic flap. We've had some patients with very large osteomata, which I suppose if you were the dyed-in-the-wool, die-hard endoscopic surgeon, you would eventually get out, but it can be so much quicker to take it out through this approach. And again, as I've already said, managing the dura is easier under direct vision and safer. So, what are the tips for the frontal osteoplastic flap? So the first tip sounds glib, but very often we do this procedure in conjunction with an endoscopic approach. We might remove the tumour up to the frontal nasal duct from below with the telescope, and then when we decide to go and get the superolateral aspect of it, we convert to a frontal osteoplastic flap. Whenever you're going to do that and you combine it with endoscopic surgery, do the endoscopic surgery first. My endoscopic skills completely deteriorate once you start using oscillating saws and raising scalp flaps and having big retractors. Your mind goes back into head and neck surgery mode, and your meticulous use of microsurgical patties goes in the bin. So do the endoscopic bit first, leave a micropatty in the frontal recess, and then turn on the rock music, get different gloves on, and start, wielding the blade and throwing drills about. Okay. This is a technique which we've used, and hopefully if you watch the video you'll see it in use. And it comes from an allied specialty, basically carpentry, and it's the technique of chamfering a cut on wood, where you make a cut at this angle here. If you make your osteoplastic flap cut through the bone with a fissure burr or a drill, you get bone loss. And when you get bone loss, you have to plate the bone flap back in position using microplates. If you use an oscillating saw and you chamfer the cut, and I try to aim for about a 30-degree cut with the oscillating saw. The oscillating saw means that you get much less in the way of bone loss, but the chamfered cut means that you can sit the bone flap back on top of the defect when you're finished. It sits there, it doesn't fall in to the cavity or the sinus, and you can keep it there using something like tissue glue, and then put your pericranial flap on top. So I strongly recommend that you don't use a drill or a fissure burr, and that you try to chamfer your cuts. As I've said, we tend most of the time, if we're doing an osteoplastic flap, not to use microplates. We sometimes use them, and you'll see them in the video for an obliteration. But we use tissue glue around the bone flap. And the key to not losing the viability of your bone flap is a big, thick, juicy pericranial flap. and being very super careful about the way you raise this, because this is what's going to maintain the blood supply. I've done a few of these now, lots in fact, and I can honestly say I've never lost a bone flap. Probably next week it'll be my first, having said that. And I think it's down to this business of using a nice pericranial flap to put it back on. I put corrugator drains in each of the corners of my bicoronal incision. I think that's important. I have had some cases where they had hematoma under the skin flap. So I think you should drain the incision. And I use a head bandage, which I take a great deal of care over putting on. And the idea is to get it to compress the area in a very general way, no specific pressure points. And you end up with this pressure bandage on, which is, I always joke to my trainees, is legal for use on a motorcycle in the UK. Okay, it ends up like a crash helmet, and that stays on usually for 24 to 48 hours. So here's a funny or a strange looking picture. This is one of the patients who you might end up doing an osteoplastic flap on. You remember, I think it was the second or third slide was a news flash that said endoscopic techniques do not always work. This is a type of patient I see quite often. They've had lots of endoscopic surgery. They've had all sorts of things done to them, and yet they have this additional umbilicus in their forehead which oozes pus from time to time. And when you look in the clinic, this is the registrar looking into the frontal recess. You could drive a bus into the frontal recess. They've had Lothrop procedure. You can stick your head up and look around. But despite that wide frontal drainage pathway, the infection still wants to come out through the patient's forehead. And this is where it's very important to realize that you cannot solve everything in the frontal sinus by just making the hole through which it's supposed to drain bigger and bigger. Okay? The plumbing model of sinus surgery is false, in my opinion. Okay? So this patient, big wide frontal recess, had a Lothrop. What do we do next? Well, in this particular patient, we used a slightly different approach. This used to be called the gull wing approach to the frontal sinus. It's sort of eyebrow, median eyebrow incision. We excised the whole tract of this, and we drilled away all of the osteomyelitic bone and accessed the sinus from above and cleaned out all of the disease that way. Patient did extremely well. Problem was solved, and the reason was the infection was an osteomyelitis in the frontal bone, and making a hole below that, I'm stressing the point here, folks, will not solve it. So, one of the other steps we can take is to say, well, if we can't drain the frontal sinus, and we can't fix it with a Lothrop's operation, and we've drilled it out and we've sent it to all the specialists that deal with this, why don't we just get rid of it? And this is an operation which we do from time to time, again with good effect. So, this patient is a different patient, but you see she has the mark, the stigmata of failed endoscopic surgery. A discharging sinus in her forehead, a sick frontal sinus, and a hole in her frontal recess which you could look up all day long. This is osteomyelitis. She's failed everything. She's failed the Lothrop. So what are you going to do? So my suggestion to you here is just get rid of it. Nobody needs a frontal sinus, especially if it's more trouble than it's worth. Get rid of it. Maybe heresy on a rhinology course, but so this is an operation looking at the osteoplastic flap, a video. Use a suture to mark the incision. This makes sure that you keep the branches of the superficial temporal artery in your flap, and it means it's easy to draw on it with a felt pen. Raise your pericranial flap. And then we use templates to mark out the frontal sinus. And we always make sure that we make our cuts inside the template, just to err on the side of caution. You see the oscillating saw being used here, and we're trying to obtain a 30-degree chamfer cut. And if you take your time with this and cut along at the 30 degree, you can then gradually lift the flap with the chisel. And if you do it correctly, as you lift your bone flap, the mucosa on the inside should be largely intact. And this person had a large extradural abscess, and we see we remove the mucosa from the bone flap, and we store that for putting back on later. So this would be standard for the frontal osteoplastic flap procedure to gain access to the sinus. You may combine it with endoscopic surgery below. A bad edit there, but what we're doing here is a frontal obliteration, and what you can see is I've cleaned all of the mucosa out of the frontal sinus. We have obliterated the frontal recess from below, and we can talk about how we do that in a moment. We've laid the pericranial flap into the sinus so that there's no way out of that sinus, and this is abdominal fat that I'm packing in to fill every corner of the sinus. The bone flap has been pushed on. It's not going to sit nicely, so we have to do something to keep it there, because you want this sinus absolutely packed. So in this case, we're using plates. The steri strips are a poor man's guard to make sure we don't drill too deep. And we put the microplates on, and then with the remainder of the pericranial flap, we're going to wrap the outside of this. So the pericranial flap is inside, but it's been cut. It's still attached. We can lay the remainder on top of it, and then clips on there, and we've already discussed the drains and the head bandage. So, that's me finished, just about, you'll be pleased to hear. What are the conclusions? So I think if you understand how the frontal sinus develops, you're unlikely to find yourself drilling and not hitting the frontal sinus. We've talked about the sweet spot with the rule of thumb for the frontal trephine. I think it's important to have an alternative to endoscopic sinus surgery. We tend to get a bit of, pardon the pun, tunnel vision. And I think if you're just continually making the frontal recess wider and wider and the patient's not getting better, then it's time to change what you're doing, not make a bigger hole. I put it to you that the osteoplastic flap is a very versatile approach, and I've already said, if you can't fix the frontal sinus, then just get rid of it. And our experience of frontal sinus obliteration has been very favourable. We've had patients with very chronic conditions who've settled down afterwards. And we've got plenty of time if there are any questions.